Good morning once again, everyone. It's 10 o'clock, so it's time to start. There is a lot to discuss today. This talk is about the detailed histology of the lymphatic organs. And last time, if you remember that, I introduced some basic terms already. We discussed what kind of cells do belong to the immune system, how do we classify them, what their main features are. This is done. You can find the lecture online as well. Now we will turn to the detailed histology of the lymphatic organs, and I also did some details. I also did some details on the thymus gland, and this is what I don't want to repeat today, but we will turn to the secondary lymphatic organs today. I will start with the lymphatic follicle here. Please note that the lymphatic follicle is a part of the other lymphatic organs. We will find lymphatic follicles in the tonsil, in the lymph node, in the spleen, and also the lymphoid tissues associated to the body surfaces is also made up by lymphatic follicles. So let's turn to the lymphatic follicle immediately, and let's go on with this now. This slide shows you a random section from the GI tract, from the gastrointestinal system, and there you can see already lymphatic follicle. And the lymphatic follicle is a quite simple structure. It is nothing else than a local accumulation of lymphatic tissue, of lymphocytes, and it's easy to recognize that you have a group of lymphocytes somewhere in the tissues. One can define usually two types of lymphatic follicles. At least most of the books use these classifications. This one is the primary lymphatic follicle, and the size of the primary lymphatic follicle is ranges between 50 to 100 microns. This is pretty small. It's comparable with the size of a single fat cell. This is, however, not that what you will see most of the times in the preparations, but it's much more likely that you will meet a secondary lymphatic follicle that is way bigger. It's much larger than the primary lymphatic follicle. It is around 200 to 400 microns. So this is already a dimension that is visible without a microscope, with naked eyes already. And this is what I would like to go into details a bit about. So this is the low power magnification light microscopic hematoxylin eosin stained image of a secondary lymphatic follicle. I think it's obvious for everyone that in the center you have a zone that is a little bit paler, and outside that you have this area which is packed with much larger with much smaller cells, which goes this quite dark color there. This area is called the cap or the mantle area, and the central zone here, which is in the middle, is the so-called germinative center, because in the germinative center the B lymphocytes will grow, will proliferate. So in the next, I would like to list the cells which one could find in the center of the lymphatic follicle. So in the germinative center, one can find fast dividing, growing B lymphocytes. Since they are proliferating cells, growing cells, they are called blasts. You have centroblasts. They are situated deeper. And a bit more in the upper area here, you have the centrocytes. These names refer to the fast developing, fast dividing B lymphocytes, which differentiate and proliferate in the germinative center. During this process, the B lymphocytes also show maturation and differentiation, and for this process, some other cells are required also which assist this process. In the last lecture, I mentioned the so-called follicular dendritic cells. They were member of the acquired immunity, and I explain you the term that the cells can perform antigen presentation. This is what you have to know about the follicular dendritic cells, that they have on their processes many antigens presented, and they will therefore support and aid the proliferation and the maturation of the B lymphocytes. On the scheme, there you can see a quite hidden cell in the spaces between the lymphocytes with their processes. They will there to show, to present the antigens for the other cells. You don't have to identify this cell for sure in the exam. It's enough if you know that they are present there with specific immunolabeling. One could mark these cells, but we don't offer those kind of preparations in the exam. Also, what you don't have to distinguish, but it's good to know that in the germinative center, although the B lymphocytes are predominantly found, some T helper cells are also present. There is a type 2 subgroup of the T lymphocytes, helper lymphocytes, which have a great significance in the control of the B lymphocyte maturation and differentiation, and they are also therefore present in the germinative center. During this B lymphocyte maturation, partly the B lymphocytes will degenerate, will undergo apoptotic procedures, and they die. And because of this reason, the dying B lymphocytes, which are eliminated by apoptosis, have to disappear, and the apoptotic remnants particles are removed by the macrophages, also present in the germinative center. So if you get a slide where you can see lymphatic follicles, and I hardly can tell you any slides in this semester where you cannot find lymphatic follicles. They are almost everywhere. But if you see a lymphatic follicle, these questions may come up. What is this? What cells do we have inside? What do they do, and what is their main function? So this is very useful to know, because in many sections, in many preparations, and in many slides, lymphatic follicles are present, and these are typical key points what one could ask. And this is also needed for the other lymphatic organs, because the lymphatic follicle is a part of the secondary lymphatic organs as well. If it's not alone, it will form groups, as you will see in the upcoming slides. But before we go there, there is one more thing what I would like to highlight, which is related to the histology in a way that one has to think in 3 dimensions, even if the section is very thin. So imagine that I cut the secondary lymphatic follicle in the middle. In that case, one can identify the germinative center right in the middle. But one can imagine that I cut the lymphatic follicle in a more peripheral area, and in such a case, I miss the germinative center. If this is the case, and if you study such a section that the germinative center wasn't hit, one may have the impression that, well, this lymphatic follicle doesn't have a germinative center, so possibly it's a primary follicle. It might be, but it's not very likely. So on one single cut plane, it's not always easy to assess if a lymphatic follicle is primary or secondary. Most likely in your preparations, you will meet secondary lymphatic follicles. But if you don't see the germinative center, it doesn't mean that it wasn't there. It just means that it wasn't in the cut plane what you are studying at the moment. So you have to think about the possibility that you missed the germinative center. Like if you cut a boiled egg, it's very likely that you cut the boiled egg longitudinally. You may cut in a way that you don't hit the egg yolk, you don't hit the yellow part of the egg, and then everyone knows that there is a yellow part in the center, but it's not necessary to hit it. So because of the same reason, one may miss it. And therefore, if you see a lymphatic follicle and you do see the germinative center, it's a secondary one. If you do not see that, it might be a primary one, but it might be also that it's a secondary one, but you missed the germinative center because of this 3D structure. Okay, this is what I wanted to tell you about the lymphatic follicle now, and let's start with the let's go on with the tonsils, and you will understand why do I why did I start with the lymphatic follicle? Because if you want to define the tonsils histologically, they are made up by lymphatic follicles. So they are structures which are formed by the accumulation of lymphatic follicles. And these lymphatic follicles are found in the mucous membranes The mucous membranes are made up by epithelial tissues, below which you have some connective tissue, and in that connective tissue you have the group of lymphatic follicles embedded, and there is no real continuous capsule around this structure. There is some connective tissue around it, but one cannot really say that it would be completely covered from all directions by a capsule, so it's incompletely encapsulated accumulation of lymphatic follicles in mucous membranes. This is what you can say if someone wants to know what is a tonsil, if you have to define it. And now I have to refer to your anatomy studies. In your anatomy classes, most likely you already met some of the tonsils in the area of the pharyngeal space and in the oral cavity. So this group of lymphatic organs will comprise the Waldeyer's tonsillary ring as well, and it has these members listed now. We have the pharyngeal tonsil, the tubarian tonsil, the palatine tonsil, and the lingual tonsil. So these 4 tonsils we have, but please don't forget that both the tubarian tonsil and the palatine tonsil are paired organs, while the other 2 are midline structures. So back to the histology, that's anatomy and it's part of other lectures, but back to the histology now. Imagine that we collect tissue samples from these tonsils and one has to distinguish them histologically. So if we take a tissue sample from the pharyngeal tonsil that is in the epipharyngeal space, which is part of the respiratory system, or one takes a tissue sample from the tubarian tonsil that is situated in the torus tubarius in the epipharyngeal space, again next to the orifice of the auditory tube, the pharyngeal orifice of the auditory tube, one can collect a tissue sample from that, and if you do a staining, you will find pseudostratified columnar epithelium with kinocilia in both, because we are in the respiratory tract, and you know that the respiratory tract carries this epithelium in the typical cases. If you have to distinguish those 2 from each other, considering the fact that the tubarian tonsil sits on the torus tubarius, which is cartilage, one will find most likely also some elastic cartilage in the tubarian tonsil section. So these 2 sections would be distinguishable based on the epithelial surface, and those 2 from each other you can distinguish based on the presence or the lack of the cartilage. Now, I have good news for you. These 2 sections we do not have in the exam section list, so you won't get these slides in the exam. But you will get most likely one of these if you get a tonsil, either the palatine tonsil or the lingual tonsil you will get, because those 2 sections we offer, and you will also study those in the practice. So how to distinguish these 2 from those 2? Considering that they are situated in the oral cavity, the palatine tonsil is hanging on the tonsillary fossa between the palatoglossal and palatopharyngeal arch. As you know in anatomy, we have the palatine tonsil that is exposed to a quite large mechanical stress because we are in the oral cavity, so a more a tough epithelium has to be on the surface, which is the stratified squamous non-keratinizing epithelium. So this is the epithelial covering of the palatine tonsil, but please note that it's impossible to distinguish the lingual tonsil from the palatine tonsil just based on the surface epithelium, because on the tongue you have the same epithelium. Again, you have stratified squamous non-keratinizing epithelium, so the epithelial surface doesn't help you. The pseudostratified columnar is found in the pharyngeal space, so those 2 you can distinguish from those 2. But if you would like to distinguish the palatine from the lingual, you have to find other features which differ. And then you turn to study the skeletal muscle tissue, because in the palatine tonsil you have less, 1 or 2 directions maybe of skeletal muscle. In contrast, in the tongue we have 3 directions of skeletal muscle, and therefore based on this feature, which is different, you can distinguish those 2 from each other. Also, you may have a look into the glands, and you will see that only few glands you can find in the palatine tonsil area. In contrast, many glands are found in the root of the tongue, which will help you to distinguish again. Also, one can study the surface epithelium that invaginates into the connective tissue a bit. That goes far from the surface. Deep crypts develop in the palatine tonsil. In contrast, you have shallow crypts in the lingual tonsil, and they are not as obvious as in the palatine tonsil. So this is how to distinguish the tonsils from each other. And let's have a look onto their histology again with some pictures. I think everyone knows where the palatine tonsil is. Here it is. It's quite big in this case, enlarged a bit, but it helps for us now. You can see on the surface these little openings. They correspond to the natural openings of the crypts, the tonsillary fossils, which are epithelial invaginations which go far from the surface. And under this epithelium, this basophilic color represents the lymphatic tissue, which is made up by lymphatic follicles on one hand. These oval structures here, quite large in the histological scale, correspond to the follicles. And between the follicles, less structured, you have many T lymphocytes as well, because the B lymphocytes are in the follicle and interfollicularly. So between the follicles, you have the T cells. You cannot really distinguish them in the microscope, but you must know where they are in normal cases. So deep crypts you have, and many lymphocytes. And also you can see in this figure that in the deep grooves formed by the crypts, there is always some tissue debris found, which is coming from the desquamating epithelial cells falling off, shedding off from the surface. And considering that you have not so many glands in the neighborhood, this tissue debris and dead cells cannot be very efficiently rinsed out from the grooves, which means that they may cause some problems. I will come to this point. Why is this? Because these deep crypts are just rinsed by very few salivary glands, and this is not efficient enough. Here is a duct, there is a mucus gland, but they won't be able to clean properly the fossils of the tonsil. Therefore, in some cases, and this is quite common in children, more common in adults, it's not as common anymore, but it might happen that you have a patient who comes with sore throat, who complains about headache, high fever sometimes, enlarged lymph nodes on the neck. And if you look into the mouth, you will see this enlarged tonsil, red, and also you have these white spots on the surface. This is a tonsillitis, it's a follicular tonsillitis, related to the bacterial infection that will start to grow. The bacterium grows on the tissue debris found in the crypts, and in this case you have prescribed antibiotics in order to prevent some late consequences and complications of the palatine tonsil infection. You will learn this in microbiology, but the palatine tonsil has infections which comes sometimes from specific bacteria which have very similar very similar structure to some proteins found in the synovial membranes of the joints and the endocardial lining of the heart. If this is the case, then the immune system attacks these bacteria, but the antibodies which are produced by the immune system against these pathogens may cross-react with the endocardial lining and with the synovial membrane of the joints, and that may lead to problems with the heart. With the patients will suffer on valve problems with their heart, and also pain in their joints. Therefore, this has to be treated on time properly. And if the tonsillitis comes frequently and returns regularly, or not regularly, but quite frequently, then the ENT specialists remove the palatine tonsil, or at least they reduce its size in order to decrease the depth of the crypts and to reduce the frequency of the tonsillitis, to reduce the risk of a later cardiac disease or problems with the joints. Okay, so this is a clinical issue related to the palatine tonsil. Due to the deep crypts and the low amount of the glandular tissue in the neighborhood, the crypts get infected quite commonly, and that's a problem. Okay, so that's the story of the palatine tonsil. And if we compare this with the lingual tonsil again, you see a stratified squamous non-keratinizing epithelium on the surface. Right under that, you have a very large amount of lymphocytes, which are again organized partially into follicles. That's the B-dependent area with B lymphocytes, and in between the follicles, you have T lymphocytes. Also, please note that the surface epithelium does not invaginate that far from the surface, maybe here a bit deeper, but it doesn't go that deep as in the palatine tonsil. Therefore, one can say that the crypts are more shallow in the lingual tonsil, and this will help you to distinguish also. But also, if you want to make sure that you don't mix it up with everything or with something else, you may have a look into the underlying tissues. And this is the tongue. So in the tongue, you have skeletal muscle in 3 directions. And one can see here vertical, transversal, and sagittal muscle fibers. In the anatomy, you will learn what are the names for these particular muscles. Vertical, transverse, and longitudinal muscles are they. But if you do the embedding in the histological specimen and the technician does her work very efficiently, then you may cut the tissue block in a way that you cut parallel with the 2, and the 3rd direction will be cut perpendicularly. So imagine here the 3 axes according to the 3 main axes of the human body, and we have muscle fibers along the y-axis, we have muscle fibers along the x-axis, and we have muscle fibers parallel with the z-axis. Now, if you take the blue plane and you cut the tissue with this blue plane, then you will get 2 muscle fibers, those along the y and those along the x-axis in a longitudinal section, and you get the cross section which runs sagittally. So you can identify the 3 directions of the skeletal muscle in the preparation. That means this is the tongue, because nowhere else in the human body we have such a situation that we have 3 muscles of skeletal directions of skeletal muscle, and then you know what your slide is. Before you go on, you may have a look into the glands once again, but with this low power magnification, you can see how many glands are found in the tissue of the tongue, which will efficiently rinse the shallow crypts, which means that the infections in the lingual tonsil are not as common as we have mentioned in the case of the palatine tonsil. Okay, so this is how to distinguish the tonsils, but because it's a common problem in the exam, I made one more slide on this issue, and this is just a decision algorithm. It's a help how to decide what slide do I have. So it's an easy thing. I get the slide, I look into the microscope, I look into the computer picture, and I see lymphatic follicles. I see many lymphatic follicles, and I do recognize the epithelium on the surface, which is part of the mucous membrane. That fits with the definition of the tonsil. It's an accumulation of lymphatic follicles in the mucous membrane. Okay, then I know I'm in the tonsil, but the question arises then which one? How to decide that? You have to ask 2 questions in the right order. The first question is, what surface epithelium do I have on the top? If I have on the surface stratified squamous non-keratinizing epithelium, I know I'm in the oral cavity. And then you must know that 2 options I have, lingual or palatine. Let's have a look into the muscle tissue. How many directions of skeletal muscle do I have? If I have 2 directions or less, I know I'm in the palatine tonsil. But if I have 3 directions, then I know I'm in the tongue, and it supports the diagnosis lingual tonsil. Just to make sure, you check the glands and the crypts. Few glands, deep crypts supports the palatine tonsil story. If, however, you have many glands and shallow crypts, that speaks for the lingual tonsil, and then you can make your final decision. This is a very, very true possibility in the exam that you have to figure out. And if you know which tonsil you have in the slide, you tell the story for your examiner, and he or she will be very happy, but we'll ask you a question. Okay, sounds good. But imagine that we do not see stratified squamous keratinizing epithelium on the top, but we do see pseudostratified columnar with kinocilia. Then you answer, okay, then I know I'm in the respiratory tract. And in order to distinguish between tubal tonsil and pharyngeal tonsil, I have to check the cartilage. And if I do not find cartilage, that is the pharyngeal tonsil. If I do find it, there is cartilage in the tissue, I'm in the tubarian tonsil. Okay, so this way you can distinguish the tonsils both in theory and also in practice if you would get the slides. Once again, we do not have pharyngeal tonsil and tubarian tonsil slides in the list of the exam questions, but we do have palatine tonsil and lingual tonsil. Please make sure that in theory at least you can distinguish the tonsils from each other by memorizing these histological features and questions, and then you will answer the questions easily. All right, tonsils done. And now we turn to the lymph node. The lymph node is a big topic. One can give several independent lectures on this single organ, but I only have maybe 10 minutes for that. So I again will point out some key things which people like or don't like that much because they cause some more problems in the exam. So first of all, this is a more or less bean-shaped organ which is covered by a connective tissue capsule. There is no epithelium. It's a properly encapsulated organ with a connective tissue border, and inside you have many lymphatic follicles again. So please note, again, I refer back to the lymphatic follicle, what I started with today. I mentioned that the tonsil has lymphatic follicles. In the lymph node, you again have lymphatic follicles. But inside the lymph node, we have areas to distinguish. We have the capsule, as I mentioned, it's connective tissue, dense connective tissue on the surface. Right under the capsule, you have the cortex, where the lymphatic follicles will dominate, and the B lymphocytes. Then you have the so-called paracortical area that is under the cortex, somewhere here. And there are the T lymphocytes dominantly present. And then finally, we have the medulla in the center, which is a spongy tissue with more B lymphocytes again. I mentioned that the organ is it's an organ that is shaped like this. And here you have an invagination. It's a bean-shaped structure. So here you have an indentation or a groove through which that is called hilum or hilus, through which blood vessels and lymph vessels pass. The blood vessels are obvious, artery and vein. They will provide the blood supply and the nutrition for the lymph node. But we have to mention the lymphatic circulation within the lymph node, which is again something that students usually have difficulties with. So the story starts with lymph vessels entering the lymph node, but they do not come at the hilum, but they come at the convex curved surface of the node. There are afferent lymph vessels which carry the lymph fluid from the periphery, from the tissues or from other lymph nodes into this particular lymph node. Then this afferent lymph vessel drains the lymph fluid into space, a sinusoid, that is right below the capsule. That is why we call it marginal sinus. And from the marginal sinus along the connective tissue trabeculae, which are connected to the capsule, the lymph fluid is drained towards the center of the lymph node. That is designated as the cortical sinus. And finally, we arrive to the medulla, where we have a sponge, and the cavities of the sponge will form the medullary sinuses. And finally, the lymph fluid exits the lymph node through the efferent lymph vessels at the hilum. So this is how the lymph circulates within the lymph node. This functions as a kind of filter which will kind of trap the bacteria, the viruses, the tumor cells, whatever, which comes eventually with the lymph fluid, which has to be attacked or which has to be trapped by the immune system, and therefore the structure. How does that look like in a low power magnification? If you compare the scheme with this low power image of a hematoxylin eosin stained lymph node, you see that this is the hilum, There you can see outside the capsule. The picture is not very nice on that, but I will have a better one. And right under the capsule, we have many lymphatic follicles, again with germinative center and with the mantle zone. After this, you have the paracortical area somewhere here. And finally, you have this very spongy-like area in the center. That's the medulla of the lymph node. Let's have a look closer. If we stay superficially next to the capsule, this is the connective tissue of the capsule. Right under the capsule, you have the marginal sinus, which collects the lymph fluid from the afferent lymph vessels. And from the capsule, you have connective tissue trabeculae, which go into the deep. Right under the capsule, in this area, you see many cells, many lymphocytes are found. And if we study that for a moment, one can already identify oval, round structures with a paler center and the darker periphery. These are the lymphatic follicles containing B lymphocytes. And here we have follicular dendritic cells, macrophages, and so on. This is what I started the lecture today. Okay, so we have lymphatic follicles in this. Between the lymphatic follicles, you have also some T lymphocytes in between those oval structures. So this is the cortex. B lymphocytes in the follicles and some T lymphocytes outside the follicles, and all the cells what we discussed within the follicles you can tell here again. Then we arrive to the paracortex. The paracortex is basically a narrower area here between the cortex and the medulla, which will be the next one. In the paracortex, we have mainly T lymphocytes. And we have another kind of dendritic cells, which are antigen-presenting cells in this area called interdigitating dendritic cells. Their name comes from their feature that the cells are connected to each other, like you put your fingers together, like invaginating into the spaces between each other. That's why it's called interdigitating dendritic cells. They belong to the immune system, to the acquired immune system as well. One more term, please study if it's about paracortex. If we have a very thin section, it's a semi-thin section, and we stain it with a dye that is toluidine blue in this case, for example, then one can find blood vessels here which have a very unique lining. They have a thicker endothelial lining that is why we call these vessels high endothelial venules. They are small veins, venules, but they have quite surprisingly thick endothelial lining. And on the top of this endothelial lining, certain proteins are expressed, which are the selectins, and the lymphocytes going through the bloodstream can easily dock to these proteins to the surface, and they can start to migrate through the endothelial lining. So the high endothelial venules are the places where the lymphocytes can pass through the vascular wall. And during this process, the lymphocytes will change their cytoskeleton as well. And this process, when they exit the bloodstream and they enter the lymph node, it's called homing, since some lymphocytes, or most of those B lymphocytes, are produced in the lymph node, and therefore they can return to their homes, and that's why the process is designated as homing. So the high endothelial venules is the place where lymphocytes can exit the bloodstream and they can enter the tissue of the lymph node. The medulla is the innermost part of the lymph node. If we study that with a low power magnification or image here, you can see this very cell-rich dark structures. They are called medullary cords. Medullary cords. In these medullary cords, you have many cells. That is why it's strongly basophilic, and you have quite large gaps between them. It's like a sponge. It's a spongy tissue. That is the medullary sinuses. I have mentioned these medullary sinuses already when I quickly summarized the lymphatic fluid circulation within the lymph node. So it came from outside, went down, and down here in the medulla it flows. It is filtered through this quite complex medullary sinus system. It's like a filter, like a sponge. So the medullary cords contain cells, and here I have to point out again the B lymphocytes, specifically the plasma cells. You know this, I told you last time that the plasma cells are responsible for the antibody production. They have an eccentric nucleus. They are quite basophilic because of their high amount of rough endoplasmic reticulum content. They produce antibodies, proteins for exocytosis. That's why the basophilic appearance. Okay, so here you have many cells, medullary cords with plasma cells, but you also have reticulum cells, since you don't forget the whole organ is supported by the reticular connective tissue. This is what I did last time, that lymphatic organs, except the thymus, have reticular connective tissue inside. Okay, this is what I wanted to briefly point out when I have to talk about the lymph node. And we turn now to the spleen. Again, the spleen is a topic on its own, and I only have maybe a few minutes to point out some key terms. The spleen is anatomically located in the abdominal cavity on the left side behind the 9th, 10th, 11th rib, and it has a great significance as a filter again. It has a very strong blood supply. The splenic artery is in size comparable with the size of your diameter of your little finger, but the spleen is only 140 gram, which fits in your palm. So imagine that an organ that is the size of your hand receives such a big vessel that is comparable with your little finger. So it's very unproportional. The spleen never uses that amount of nutrients and oxygen, so it has to be something else, and that's the filter function. So it's a quite considerable proportion of the cardiac output is transported to the spleen in order to filter the blood. If there is some bacteria in the bloodstream, viruses, and so on, the filter works and removes those from the bloodstream. Also, you know from your earlier studies about the blood that the erythrocytes, if they get 100 days old, they have to be removed and recycled. This takes place in the spleen. All the erythrocytes are removed there. Blood production does not take place in the spleen normally, just in embryonic or in fetal life. After birth, only in some diseases, bone marrow diseases, the blood production may eventually return to the spleen, but that's not normal at all. The blood storage function in humans is not very characteristic. In animals, in cats, for example, in big cats and lions and in tigers, for example, we have a quite considerable blood storage function, but not in humans. But in humans, the the platelets, the thrombocytes, are stored. At least their 1/3 is stored in the spleen. The capsule of the spleen is connective tissue, but it contains some smooth muscle, and this is related to the blood storage function in many species. In humans, this is subordinate, but in many species, if the animal has to run, for example, in predator animals like in big cats, if they have to hunt an animal which is running also quite fast, in very short time they have to increase their speed, so they have to reach a higher oxygen transport capacity, and therefore we have the spleen which contracts in those animals. The smooth muscle contracts, and the blood of the organ stored inside is pumped kind of into the bloodstream, and that increases the oxygen transport capacity of the animal, and therefore the animal can run faster. In humans, this is not very characteristic, but some people have some pain. If you do exercise, you might have realized a quite uncomfortable pain behind your ribs on the left side. That is sometimes the contraction of the splenic smooth muscle capsule, which hurts. You have connective tissue trabeculae, which go into the deep, and the spleen tissue is divided into two main parts. You have the red pulp, and we have the white pulp. The red pulp is larger, the white pulp is less, and the red pulp contains many blood cells, erythrocytes, because they are broken down there, and the white pulp is the lymphatic tissue that contains the lymphocytes, and I'm showing you these images to demonstrate that. So this is a low power magnification of the spleen. On the top, you have the capsule. The capsule is quite tiny. It can break. You know the story of spleen ruptures after a car accident, for example. Sometimes surgeons have to remove the spleen, therefore, and that will, of course, interfere with the immune system's efficiency. Now, under the capsule, you have the red pulp. This is eosinophilic, many cells, erythrocytes mainly. And these, for us now in hematoxylin eosin staining, blue, purple areas correspond to the white pulp. This is the white pulp. If we go closer, you can see many lymphocytes in the proximity of the blood vessels. That's the white pulp. They kind of surround the blood vessels. And here you can see how the blood vessels are organized in the spleen. This is again a question in the exam which comes up, but people don't usually answer these questions properly. So I briefly summarize this story with this figure coming from one of your textbooks. So the splenic artery enters, it splits into the trabecular arteries, they run in the connective tissues. And then they give off the central artery that runs in the center of the lymphatic tissue, which belongs to the white pulp, and that's called periarteriolar lymphoid sheath pulse. And this actually contains T lymphocytes. The central artery has many branches. It has side branches. They will provide the blood supply for the lymphatic follicles, where you find the B lymphocytes, and that blood is drained to the marginal sinus. Then the main artery, the central, goes on, and in one spot, basically at one place, it splits at the same time into many smaller branches, which are called penicilliform arteries. It's like a paintbrush. That's why the name penicilliform arteries. And the penicilliform arteries continues into capillaries. They are called ellipsoid arteries, also called sheathed capillaries, because they are first, people thought these are arteries because they have a thicker wall, but it later turned out that they are specific capillaries with macrophages, plasma cells in their walls. And ellipsoid arteries, or with the other term, sheathed capillaries, have two options. Option one is that they are discontinuous and the blood exits the vascular space and it is drained into the red pulp outside the blood vessels. And finally, it is collected by sinusoids and it's drained into trabecular veins. The option two is that you have some sheathed capillaries which are already directly continuous with sinusoids, and in that case, we talk about a closed circulation, and the way into directly to the sinusoids goes through the venules into the trabecular veins. So in humans, both the open and the closed circulation exists parallel. How does this look like at the cellular or histological level? You have the blood vessels, which have longitudinally running endothelial cells. And these endothelial cells are quite specific because they leave some gaps between each other, like the staves of a wine barrel here. You have some clefts between those, and the blood cells can come and go. And other kinds of sinusoids which have a continuous wall, which belong to the closed circulation, the red pulp, have a continuous wall where there is not enough space for the erythrocytes to pass. And the whole system is made up by the reticular fibers forming these ring-like hoops of the barrel. Okay, so this is how the sinusoids look like. This you won't see in the microscope, but in theory it's good to know. I mentioned the B and the T lymphocytes in the spleen. Around the blood vessels in the pulse, you have the T lymphocytes, and you have lymphatic follicles in the spleen, also where the B lymphocytes are found. You will see a preparation in your practice. Your teacher will demonstrate that. This is an immunolabeling in which we did a brown staining for the B lymphocytes in this preparation. And there you can see that the follicles are brown. And on the other side, we did the next section from the same tissue sample again, we did an immunocytochemistry, but there we marked the T lymphocytes, and you can see that around the blood vessels, the tissue got brown. Okay, so the area which is here pale turned brown on the other one and the other way around. So in this slide, one can see the T lymphocytes in brown, and in this slide, you can see the B lymphocytes in brown. One can distinguish these cells with corresponding technique. In the classes, you will see these demonstration materials. Also, it's not an exam slide, but one can do that. You can distinguish the cells. Okay, we are almost out of time, so therefore, I just want to say one sentence about the body surface associated lymphoid tissues. We have those associated to the mucosa, to the gut, and to the bronchi. And also we have immune cells in the skin. I mentioned last time the Langerhans cells. But when you study the slides in the coming semester, you will see many, many times tissue samples, for instance, from the ileum or from the appendix here. All the slides will contain more or less lymphatic tissue. In the ileum, you have many lymphatic follicles. These will be the pairs, patches, or plaques, and also similar lymphatic follicles you have in the appendix vermiformis. So please keep in mind that the immune system is always there to protect the immune system, and one can always ask the question, what is this? This is again a lymphatic follicle in the wall of a bronchus, and this should protect the respiratory system from infections, and this is why we have lymphatic follicles here also. And you never know when the examiner will ask you, what is a lymphatic follicle, what kind of cells does it contain, and what do I have to know about that? Okay, so I think the time is over. This is what I could tell you here in this short time about the lymphatic system. The rest you can find in the books, and please use this lecture material, the video, the slides of the lecture, and please feel free to study that. And I hope I could take you closer to the understanding. Thank you for your attention.